This section will cover cholinergic and anticholinergic drugs of the peripheral nervous system. If you have not watched the lecture on the peripheral nervous system, I urge you to do so now and memorize the chart because it'll make memorizing these drugs much easier. Let's start with muscarinic agonists. These are going to pretend to be acetylcholine at the muscarinic receptors, meaning that they're going to cause a parasympathetic response. Everything in the body will slow down except for the GI tract, which is where we get the rest and digest saying. For uses, think of anything that increases secretion, so that may be saliva in the mouth, tears in the eyes, or urine output in those with retention. The side effects are just a more severe version of the mechanism of action, and they can help us remember the precaution and contraindications. For example, you won't want to use a drug that causes bronchoconstriction in those with uncontrolled asthma. Similar explanations are available for each of these. You can go through them one at a time on your own. The interactions are going to be drugs that block this receptor because we're trying to activate it. So it's the exact opposite of what we want to do. Let's move on to cholinesterase inhibitors. As we talked about in the Introduction to Neuropharmacology lecture, neurotransmitters turn off the system only once they're removed from the synaptic gaps. So that's done by either degradation, diffusion, or reuptake. These drugs will prevent the breakdown of acetylcholine so that more of it's available and the system continues to turn on. These are our primary drugs in myasthenia gravis for either treatment or diagnosis. The drug of choice is here, and there are both reversible and irreversible agents for cholinesterase inhibitors. The side effects are virtually the same, except for at toxic doses, they can have a neuromuscular blockade. Atropine can reverse the effect of all of these cholinergic drugs. However, reversible cholinesterase inhibitors must be given IM, IV, or sub-Q, not orally. They are also degraded by cholinesterase. These two drugs are just a continuation of the category above. However, physostigmine is the drug of choice for treating atropine poisoning. This must be given in a slow IV administration in order to avoid the severe parasympathetic side effects. Other cholinesterase inhibitors, are used in Alzheimer's, but we will talk about them in the CNS section. Irreversible cholinesterase inhibitors aren't really used anymore. This is the only approved drug currently on the market. It's rarely used in glaucoma. The reason is because these are highly toxic drugs. They're used in insecticides and as a nerve agent. So in order to reverse this toxicity, we use pralidoxime. However, it cannot cross the blood-brain barrier, so we must control the side effects, including convulsions with benzodiazepines and atropine, which can cause some diminished effect throughout the system. These are highly lipid soluble and readily absorbed, so they don't even need to ingest this drug. Simply by touching it, it can be absorbed into their system. If you forget everything we just talked about, that's okay. Choose one of these two mnemonics and memorize it. It's a muscarinic cholinergic toxicity. This is what occurs. They both have the same information in them, but what it can essentially tell you is all of the uses, the side effects, and the contraindications and precautions for the drugs. Now let's move on to muscarinic antagonists. We're mainly going to talk about the first three. These are anticholinergic drugs. They do the opposite of the cholinergic drugs, so they are blocking the acetylcholine muscarinic receptors. This means that they increase the parasympathetic activity, so everything speeds up except for that GI tract. They have very different uses. You'll see atropine used most for bradycardia, can be used for eye surgery, as well as an antidote to poisoning. Scopolamine is used for motion sickness, as well as those eye surgeries. Think about your parasympathetic versus sympathetic system. If you're running from a bear and you have the sympathetic system turned on really high, you want your eyes to dilate as much as possible in order for you to see all of your surroundings. So that's why it's helpful in eye surgery. Ipratropium bromide will be talked about more in the pulmonology section. However, asthma, COPD, and rhinitis can benefit from this drug because it can decrease secretions and it can bronchodilate. The side effects, once again, are just an extreme version of the mechanism of action. The interactions include drugs that also block the muscarinic receptors, because we don't want to risk putting somebody into toxic doses, which can cause hallucinations, coma, and respiratory distress. Don't use these in an older adult. Anything that has anticholinergic effects, we don't like to use in older adults. They're going to see very high levels of these side effects. Now, there are several other sections under here that you can see, and they're not used very frequently. Additionally, we'll talk about these in drugs for glaucoma or Parkinson's, and the overactive drugs will be in another section as well. What I do want to note is that these two drugs cause prolongation of the QT interval, as well as all of these drugs are metabolized by CYP3A4, so they're going to have a lot of interactions. Finally, anticholinergic toxicity can be remembered by this mnemonic right here. Remember that sweat glands are activated by acetylcholine, so by blocking those, you will get these first three side effects: hot as a hair, dry as a bone, and red as a beet. Blind as a bat comes from the severe mydriasis and inability to focus your vision, and mad as a hatter from the hallucinations, delirium, and even coma that can come from toxic doses. Over here you can see two graphs that talk about the dose-related effects of atropine.